So you get a patient who's diabetic in the emergency room, and you decide you want to admit the patient. You go through medication reconciliation with the purpose of starting their inpatient medications. The patient may have a procedure, the patient may be going for a surgery. You may not necessarily be an internist, an endocrinologist, diabetologist, or someone who is very well capable of dealing with diabetic medications. The general rule is you stop oral hypoglycemic agents and you start the patient on some form of insulin. The usual mistake is that patients are put on a sliding scale arbitrarily based on what is available as an algorithm or a power order set in the hospital, or a certain protocol that is in a printout depending on what kind of a hospital system that you're in. And then the patient is left and they would have fluctuations of blood sugars. The patient might pose a certain challenge to you as they are not presenting to you the exact medications they're on. Their level of consciousness may be acutely affected, or they simply may be a poor historian. And so you have to really know. The first thing you need to know, and that is commonly neglected, is actually do try to get their exact home medications and reconciliate them. There are certain admissions where the patient will not undergo a lot of metabolic stress and are there for elective reasons, and it may be okay to keep them on their metformin, which might happen to be the only medication they are on. You can always seek the aid of someone who's an expert and refer them to a diabetologist to look up their care. But that alone is not enough, because between the night and the time that the consultation team may come to see your patient, adverse effects can happen. One of the worst things that can happen in a hospital is that a patient can go in a diabetic ketoacidosis when they're in the hospital. And that would be a grave mistake on the part of the primary team and the admission officer. And so you want to be sure if the patient is type 1 or type 2. So here is your first trick. Talk to your patient and know when the onset of diabetes is and if they have always been on insulin. That way you know if they're type 1 diabetes, or at least this is a really good way to have an informed guess that this is type 1 diabetes. Make sure that all the patients have some form of insulin coverage 24-hour. And at the same time, you want to make sure that the patient does not go in hypoglycemia. You want to remember, as another general rule, that hypoglycemia is more dangerous than hyperglycemia, because you were talking about 3 to 5 minutes when you may sustain some form of permanent brain damage. So now you want to prescribe your basal bolus insulin. And the way to go about that is to try to know how much total amount of insulin you want to give per day, and half of that would be the amount that you give as a long-acting insulin in the form of bolus to your patient. And so assume the patient at home takes about 60 units in total. That means about 30 of that will be in the basal bolus. Just because the patient comes in the hospital and just because the other 30 units or so are going to be given in terms of sliding scale, which means you're going to measure the amount of insulin in the blood and you're going to give an amount that is based on the scale that you chose, whether it's like low dose, say for example, it starts from 2 units and then the maximum is about 12 units, versus a high dose where it starts from 4 but the maximum is like 40. That means you can adjust for the extra needed. A really good rule of thumb is, because one of our goals is to never cause the patient to go into hypoglycemia, is to only give 70% of what they have already been taken, or what the calculated amount is about. And so we give them 70% of the amount that is needed. So that means I already calculated 30 units to be the basal bolus amount that I need for my patient. So I'm going to give them 70%, or an arbitrary amount that's about 70% of that. I can go ahead and give them, for example, 20 units of glargine once daily, or 10 units of detamir BID, or even 10 units of glargine BID. It can be even 10 units of NPH BID. And it can even be divided into TID and pH as a basal bolus, because the idea is to try to not have too many dips peaks and troughs in the amount of plasma in the blood. I'll put a little graphic to explain what that is about. So that's one way to calculate the basal bolus. Try to understand that what you really need to do is you need to know how much basal bolus to give, because that is the dose that you are responsible for. As for the sliding scale, at the time of the meals, it is only which scale to choose. If the patient is newly diabetic, choose the low dose scale. If they are newly type 1 diabetic, choose the low dose scale because they will be sensitive to insulin. They're mostly insulin naive. If they are someone who has been well controlled on only one oral hypoglycemic, choose the low dose scale. If there's someone who has been a diabetic for some time, maybe less than a decade, and they're on 3 or so medications, or they're taking higher doses of one medication and metformin, or if they have recently started on insulin and they're well controlled, then go with the intermediate dose, intermediate scale. Most of the patients will require intermediate scale. And then those who clearly are in metabolic syndrome, someone who's hypertension, dyslipidemia, diabetes for a long time, they're on insulin, and they're on insulin for a long time and they're not compliant or they're not well controlled, you can go ahead with a high scale. One way to go about that safely is you can start the patient on an intermediate scale and then upgrade them 24 hours later if you're still afraid of hypoglycemia. So there is a clinical judgment and a clinical call that you can accurately and safely make when you see your patient in the emergency room. And so now we have stratified our patients into different groups. Those who are already on insulin, we ask them about the amount at home. So please, when you refer your patient to the diabetologist, ask them what type of medications they're on and how many units total. The beautiful thing is that all types of insulin, unit is a unit. So you can just count, you can add all the units they take, and you can call your diabetologist and tell them, I have a 58-year-old man who's hypertensive diabetic for the past 15 years. They're on insulin and they take a total of 30 units per day in addition to metformin, for example. And at that time, I accept from you to say, oh, I'm not really sure about the different brands of insulin. They showed me some dark blue pen and another orange pen. I can perfectly accept that. Those are the insulin pen cartridges that are used as injections subcutaneously. So it's really nice to get in the habit of knowing those things. And that way you would prevent your patient from going into hyper or hypoglycemia episodes. So final thing to discuss is the concept of what we are doing. By putting a patient on a sliding scale, you mimic normal physiology. So the normal physiology is we always have a basal amount of insulin ongoing in our body throughout the day. And that helps the body utilize glucose and even allows potassium to enter the cell amongst other functions. And so this kind of like acts as the key to the cell to open a gate, which is basically a protein that allows the glucose to enter the cell, and that we utilize it. Have you ever wondered why a patient who's diabetic gets massive amount of hyperphagia? They are very hungry and they want to eat more. One way I explain to my colleagues and even to students that I have taught before is that the body cells get extremely hungry and they are seeing a lot amount of glucose out in the blood. I'm personifying the body cell. Imagine the body cell is actually seeing glucose, like seeing this really nice, delicious glucose meal in the blood, but there's no insulin, or there's a lot of insulin, but there's resistance to the insulin, so they can't take it inside and they can't feed. And therefore, they just get hungrier and they get angrier, and that even kind of explains why in diabetic states cells release a certain amount of cytokines, and there's a low-level inflammatory state that kind of helps participate in a lot of detrimental effects on the body that is in addition to the oxidative stress and the stress that occurs directly by glucose interacting with endothelial cells, nerve cells, and so on. And so that is the basic fundamental thing that's happening to the body. And so when you control the diabetes, you actually get better results in terms of all of those things, including the hyperphagia. That kind of tells you why it's important to have a basal amount of insulin all the time functioning, because you may eat 3 or 4 times, but your body is constantly utilizing energy. And I have a proof of that, because you're alive. You won't be alive if you're not utilizing energy. And so don't deprive your patient from their basal insulin, which is the common mistake that I am seeing, especially from surgical specialties and sometimes even from the internal medicine resident and internal medicine subspecialties, which is really not acceptable. And the only things that you want to be careful of is someone who has history of labile diabetes. You can tell if they have a glucagon pen that is prescribed to them. At that time, you may want to consult the endocrinology or diabetology teams right off the bat. Or if you are really not confident to start, then also consult. Seeing the management of those patients a couple times will help a long way. And someone with end-stage renal disease or chronic kidney disease, those are people that you may also want to keep them on sliding scale only, and I will give an allowance for you to not give them the basal bolus, simply because the insulin will remain in the blood for a longer time, and then involve people in the morning from the diabetology and endocrine team, and they might very well prescribe a basal bolus at that time, but at least you're trying to always stick to the rule that we will never cause hypoglycemia to any of our patients. And then finally, the last note I want to mention is that prior to any surgical procedure, especially those that the patient goes under general anesthesia, the mainstay is to generally put the patient on an IV infusion of insulin. So you want to make sure to know what is your hospital policy, to either consult the diabetology team or the anesthesia team, who will be in charge of initiating that IV insulin. And the IV insulin idea is you're going to be giving insulin IV, but it's also going to follow a sliding scale per interval. So they're going to check RBS, and based on that, they'll adjust the amount of IV insulin, which might be something like 2 units per hour, and it might be something like 20 units per hour. It really depends on your patient. And then finally, it's also really nice to be able to expect those that will have unfavorable outcomes, like they'll remain uncontrolled, and they'll be very much uncontrolled on large mega doses of subcutaneous insulin that you might choose to go IV. So remember, everything we talked about today is actually subcutaneous, except for when we talked about the IV with the perioperative situation. The other time we start an IV infusion of insulin based on a sliding scale, of course, and always, is those who are extremely uncontrolled. So what I was trying to say is, how can I expect those patients? So imagine someone who's been diabetic for a long time, on insulin for a long time, high dose of insulin for a long time. They're already overweight and they have all the complications and things that can give us an idea that they are insulin resistant. And they recently had a kidney transplant and they're on large dose steroids every day. Or they have an autoimmune disease and they are taking pulse steroid. So steroid, basically large doses of steroid in someone who's already a requirer of a high scale sliding scale or high dose of cumulative insulin per day. Those are patients that you might also consider for IV infusion. So now you know how to initiate a sliding scale, and now you know how to consult your colleagues to really affect that sliding scale in a manner that may very well be useful. It's been a pleasure presenting this topic to you, and I hope that it makes a difference in your patient care. Take care.